My name is John Fair, and I will be presenting this video in the RPVI curriculum focusing on hepatoportal ultrasound. The references for these slides are Strandnest's Duplex Scanning in Vascular Disorders 5th edition textbook and the RPVI and Vascular Lab online curriculum. The focus of this presentation will be the RPVI curriculum as it applies to the hepatoportal duplex in both native and liver transplants. We will understand the physiology of the internal organ circulation and hepatoportal venous system by explaining the normal vascular anatomy, anatomic variants, and incidental findings, as well as the physiology of the hepatic circulation and hepatoportal venous system. By understanding these things, we will have a thorough understanding and interpretation of hepatoportal ultrasound studies and the normal and abnormal flow patterns associated with hepatic allografts. The hepatoportal duplex is performed with a 2 to 5 MHz curved array in a fasting patient. In regards to normal vascular anatomy, there is the portal vein, which contributes 75% of the blood supply to the liver. It is formed from the superior mesenteric vein and splenic veins. The direction of flow is important here with two major terms to consider: hepatopetal flow, which is flow into the liver, and hepatofugal flow, which is flow out of the liver. This is not uncommon in liver disease and can be seen in patients with cirrhosis and portal hypertension. In addition, we can see pulsatile flow, which usually reflects right heart failure or strain. The hepatic veins often have branching patterns, and they have a distinct waveform shape that reflects the cardiac cycle. Visualization, however, may be difficult with patients with small liver or ascites. When we first begin scanning, we look for normal vascular anatomy. This is performed with grayscale imaging, where we evaluate the liver for size, echo texture, surface contour, focal liver lesions, ascites, and varices. Afterwards, we image the vessels. We look first at the portal vein. This is obtained with oblique imaging, aiming towards the right shoulder. The normal size of the portal vein is 7 to 15 millimeters, but may be increased in patients with portal hypertension or decreased in the presence of collaterals. Normal portal venous pressure lies between 5 and 10 millimeters of mercury. In regards to the Doppler waveform, normally for the portal vein it is a low velocity with mild variation as seen in the upper right-hand corner of the screen. Continuous hepatopetal signal is also normal, and increased pulsatility is also normal. The hepatic vein, on the other hand, has a pulsatile waveform which reflects changes in the right heart. Flow is hepatofugal and can be broken down into four major components: the S phase, which is filling of the right atrium during ventricular systole; the V phase, which is overfilling of the right atrium before tricuspid valve opens; the D phase, which is filling of the right atrium during ventricular diastole; and the A phase. This is right atrial contraction with a reverse flow into the liver. This phase can be accentuated in patients with tricuspid regurgitation. There is often loss of variation seen in cirrhotics, which is seen in the image on the bottom of the screen. The purpose of obtaining a hepatoportal duplex is to understand the physiology of a patient's hepatic circulation and hepatoportal venous system. However, there are some limitations to this type of study. The Doppler only gives indirect information. You may be able to diagnose splenomegaly, ascites, the stigmata cirrhosis such as portosystemic shunts and varices, but the hepatoportal duplex cannot tell the degree of portal hypertension and does not tell the volume of blood delivered to the liver. There are some indirect signs that we may be able to look out for. For example, the portal vein does increase in size with portal hypertension, and as flow in the portal vein decreases, flow in the hepatic artery typically increases, and this may be seen on duplex with a dilated and tortuous hepatic artery. However, these findings cannot be used to assess the severity or progression of portal hypertension, although increased varices do appear to be related to severity of liver disease. The causes of portal hypertension can be broken down into four different categories: prehepatic, intrahepatic, posthepatic, and hyperdynamic. Portal hypertension in the prehepatic realm is usually caused by portal vein or splenic vein thrombosis. Intrahepatic can be further broken down into presinusoidal or sinusoidal. Presinusoidal is usually due to things like schistosomiasis, sarcoidosis, or primary biliary cirrhosis. Sinusoidal may be due to alcoholic cirrhosis, cryptogenic cirrhosis, postnecrotic cirrhosis, or viral hepatitis. Posthepatic can be due to things like IVC obstruction, right heart failure, constrictive pericarditis, and severe tricuspid regurgitation. Hyperdynamic usually refers to AV fistulas. As we move forward in the curriculum for the RPVI, we will now go over the physiology of hepatic circulation and hepatoportal venous system. We'll discuss collaterals, intrahepatic blood flow patterns, extrahepatic blood flow patterns, thrombosis involving the portal system, and portal systemic shunt evaluation. The hepatic circulation and hepatoportal venous system have many different collateral pathways. These can be seen in the diagram to the right. Gastroesophageal varices are often the most clinically significant. The coronary vein feeds the esophageal varices. The coronary vein is considered abnormal if flow is heading toward the head or if the diameter is greater than 4 millimeters. Also important are patent paraumbilical veins. They run in the ligamentum teres between the medial and lateral segments of the left lobe of the liver. They extend from the left portal vein towards the capsule of the liver and drain into the inferior epigastric vein. They are considered abnormal if they are greater than 3 millimeters in size or if flow extends beyond the liver capsule. Also important are the splenorenal and retroperitoneal collateral pathways. When assessing hepatic circulation, we want to evaluate intrahepatic flow. This is usually determined by evaluating flow in the main, right, and left portal veins. Flow is usually all hepatopetal, which, as we recall, means flow into the liver. This is usually visualized mostly in the main portal vein. While hepatofugal main portal vein flow is rare, it may indicate portal hypertension. Furthermore, the right portal vein may also show some hepatofugal flow. There are some medical conditions that we should be aware of when evaluating the hepatic circulation, the first of which is Budd-Chiari syndrome. This is venous outflow obstruction and can be at the level of the hepatic venules, large hepatic veins, or the inferior vena cava. All or some of the veins may be affected. The primary cause can be intrinsic venous problems such as thrombosis, stenosis, or webs, and may be due to hepatic venous thrombosis, inferior vena cava thrombosis, or webs in the hepatic veins. Secondary causes are usually extrinsic compression, such as malignancies involving the hepatic veins or the inferior vena cava. When evaluating patients with Budd-Chiari syndrome with ultrasound, we often see hepatomegaly with hypertrophy of the caudate lobe. We may also see ascites and findings of pulmonary hypertension. There may be absence of flow with echogenic intraluminal thrombus or non-visualization of the hepatic veins or the IVC. Thrombus may also be identified, or the vein can be obliterated. Furthermore, there may be intrahepatic or capsular collaterals. A dampened, monophasic Doppler waveform in the peripheral hepatic vein suggests more central obstruction. Portal venous thrombosis is another medical condition that we should be aware of in our evaluation of the hepatic circulation and hepatoportal venous system with ultrasound. These can be either acute or chronic. The most common causes of portal venous thrombosis is cirrhosis, hypercoagulable states, and neoplasia, like hepatocellular carcinoma and pancreatic cancer. In acute portal vein thrombosis, the portal vein is often distended, while in chronic portal vein thrombosis, it is small and fibrous. Absence of signal by color Doppler should be seen and confirmed by sensitive pulse Doppler. The presence of arterial flow within the thrombus can often be used to distinguish malignant thrombus from bland, and these are called neovascular signals. Periportal collaterals may also develop in the thrombus. This is usually 6 to 20 days after the development of the portal venous thrombosis, and this is called cavernous transformation of the portal vein. Screening of a transplanted liver is a normal part of the hepatoportal duplex. This is performed daily for the first 3 days postoperatively, and then subsequently on the 1st, 6th, and 12th months. Doppler waveforms of the main, right and left, hepatic artery and portal veins, and the right, middle, and left hepatic veins, the IVC, and the aorta are performed. The resistive index is also calculated, which is systolic minus diastolic divided by systolic, as well as the peak systolic velocity and acceleration time. The acceleration time is the time interval between the onset of systole and the first systolic peak, and should be measured in the main, right, and left hepatic arteries. In the normal hepatic artery waveform, there's a sharp systolic upstroke with acceleration time of less than 0.08 seconds. There should be continuous forward diastolic flow, a resistive index between 0.5 and 0.8, and a peak systolic velocity less than 200 centimeters per second. In addition to this, we also visualize all vascular anastomoses. The portal vein should have a normal waveform. However, the mismatched diameter between the donor and recipient should not be misconstrued as a portal vein stenosis. The IVC and hepatic vein should be triphasic, pulsatile waveform, reflecting transmitted cardiac pulsatility with predominantly hepatofugal flow, except during the A wave, which again corresponds to the right atrial contraction. Monophasic hepatic venous flow usually is abnormal and nonspecific, but may be due to external compression of the IVC or the liver. Accentuated pulsatility in the IVCs or hepatic veins may be common in the immediate postoperative period, but also may be due to right heart failure and can be exacerbated by patients with volume overload or tricuspid regurgitation. There are several abnormal flow patterns associated with hepatic allografts that we should be aware of. A decreased diastolic flow resulting in elevation of the resistive index greater than 0.8 is commonly observed in the immediate postoperative period. For hepatic artery stenosis, we may see a high peak systolic velocity above 200 cm per second, as seen in the image to the immediate right. However, parvus tardus waveform is most common, and that is seen in the other image to the right. Here, a resistive index is usually less than 0.5, and the acceleration time is greater than 0.8 seconds. For hepatic artery thrombosis, we will see absence of flow in the main and intraparenchymal hepatic artery using color, power, and spectral Doppler. Hepatic artery pseudoaneurysm may also be encountered. This is often due to infection or poor surgical technique. On grayscale, we will see a cystic area. On color flow, we will see a swirling blood flow in a yin-yang pattern. Hepatic artery to portal vein fistulae may also happen. These are rare and may occur after liver biopsy. Most do resolve spontaneously. There is a focal color buoy in the surrounding soft tissue, high peak systolic velocity and end diastolic velocity isolated to the feeding artery, and pulsatile flow with increased velocity in the draining vein. Duplex examination following liver transplantation is a standard part of the postoperative period for liver transplant patients. It is important for screening patients for vascular complications and can help diagnose conditions which threaten graft and patient survival. Thank you.